and then look at that. Dr. Kansuk, are you introducing?
While Manik takes time to come on the scene, let me just say what a great guy he is, who did such a good job with the telemedicine practice guidelines program for Telemedicine Society of India and for TH India, in which Sathi was also involved in a big way. Yeah, so that was early last year, in March, April, May.
Thank you, Dr. Jaya. Thank you, Dr. Sashi, and thank you, Dr. Colonel Binu. Both Dr. Sashi and Dr. Colonel Binu have set it up in a perfect way for me to be able to present our case study. We were in the field as per other nurses and other people. We documented what we did, and we are hoping to present it in a cogent manner that makes sense with what the earlier speakers have also said. With me, I have my nursing head, Anupreeta. So the theme for International Nurses Day, May 12, 2021 is Nurses, a Voice to Lead, a Vision for Future Healthcare. And that actually ties in with WHO's tagline for the year of health and care workers, which is Protect, Invest, Together. Thank you. Thank you, Pawan. So telehealth nursing or telenursing, I'm just going to give you a brief. Both the speakers have given a whole lot. So it is a use of technology and telemedicine to conduct nursing and deliver care in a remote location. It can be conducted anywhere, wherever there is proper technology that is available. Nurses, of course, can monitor a patient's oxygen level, heart rate, respiration, blood glucose, and a lot more other parameters that are possible, and just being able to get the various symptoms from them. And of course, in non-emergency situations, nurses can also instruct patients as to address a wound or treat a minor burn. Next, please. So telemedicine practice guidelines has this flow chart, a very simple flow chart that shows how the health worker and an RMP, registered medical practitioner, put together. Next, please. So that very clearly shows the various aspects of how to do it. So it is already laid out in our TPG or telemedicine practice guidance. So with that as the source, we went ahead and started looking at what can be done. And what can be done is, when getting a patient is difficult to get from a physically distant location or remote location, after a natural disaster, especially when the lines are up. Until then, maybe the lines are all down. So the first person to come up is probably a nurse who can triage, who can find out what's happening on the ground. And of course, in our current situation with the pandemic, we have been able to get access to patients who probably had only a simple keypad. And of course, in normal times, we should be able to do it in pre-surgical and post-surgical care. And as Dr. Binu had mentioned, someone is paralyzed, we should be able to get help to them also. Next, please. So competencies of a nurse are essentially what Dr. Binu had already said. I'm just going to show out 3 or 4 of them, how to ensure that our nurses know what exactly they need to be able to handle this. And of course, to participate fully as a member of the healthcare team, not just she or him by herself, but as an entire healthcare team comprising of probably even a volunteer on the ground and definitely a doctor on the other side. Next, please. So what can a nurse not do? Now, this was very important for us. When we started out on our project, we wanted to make sure that all of our nurses knew very clearly that they cannot certify tests. They cannot make diagnosis. They cannot prescribe medications and treatments. They could give simple instructions like, please go ahead and steam inhalation. Or maybe they can say, don't use it 5 times a day, maybe twice a day. So simple things that have been given a standing instructions by a doctor for a patient. Of course, they cannot do surgeries. Very importantly, they cannot share work-related information or the patient's information with anyone. In short, they cannot engage in any tasks that need the input of independent medical judgment. That is for the medical practitioners. Our journey, we started out with the telemedicine practice guideline that was published on March 25th, 2020. And as Dr. Jaya said, we were part of a task force where we were training doctors on telemedicine. And we also simultaneously from our company, we started looking at how we could potentially use this in our situation. We had already been in telecardiology. So this proved to be a good situation where we could apply the same technology into this entire pandemic. And sure enough, our peak in wave 1 was in July, and it kind of tapered down. And during that time, if you can go to the next slide, please. We had a simple model. We had the patients who would call in. We had a care center. We also had an app where they could key in what symptoms they had. And we created a dashboard that we passed on to a doctor. And the doctor would look at the dashboard, which I'll show shortly, and he would consult and advise the patient. And it was mostly for situations where the patient needed to know whether they needed to be hospitalized or not. So at that time, it was still a calm enough scenario that patients could wait for a doctor and receive some instructions. Next, please. And so the dashboard was actually of 2 parts. And next slide, please. The first part is actually, if you go to the next slide, the first slide was basically a record of all their symptoms in increasing order of intensity. So we could have headache, we could have lost sense of smell and taste, and so on. So this particular dashboard gave the doctor, okay, as to how long or what are the various symptoms that have been present for this particular patient. Next slide. And there was also another part of the whole thing, dashboard, that had tracked the SpO2 or the temperature or the respiration rate or an MRC score for breathlessness. So we had all of this, and when we put these 2 together in one sheet, we gave it to a doctor, the doctor was able to say, okay, I think I know where this patient is headed. The patient can stay at home or the patient can go to a hospital. Next slide, please. Wave 2, we did a little bit more than wave 1. What we did was we allowed the patient to call. This time, there was so much of panic all around that they did not have time to do anything other than call. So we did away with the app. We said, we don't need any app. We don't want them to go ahead and spend even those 2 minutes because they're already in a panic. So they would call. Our call center would then go ahead and nominate one of our nurses. And the nurses would then go ahead and do a triage. They would do a triage of the patient, a complete triage, in their past medications, past surgicals, past medical conditions, allergies, all the classic ones that we needed. And they would jot it down in a particular format. We also had a checklist. And they would then brief the doctor. Until then, the doctor and the patient have not met. The doctor listens to the briefing and he asks a few questions if he needs clarity. And then he says, let's go on a video call with the patient. And when he talks with the patient, he now has a good attention of the patient because he says, I saw your article and I saw your diabetes. And so within
Hello, Mr. Manik sir, your net is not working, I believe.
Can you hear me now?
Yes, sir. Yes,
okay.
Sir.
And so he would say, tell the patient, the nurse will call you. And sure enough, the nurse will call with a set of documents And what we also did was the easiest way of communicating with the patient, especially in urban settings. And most of our patients were in the urban settings. And in the urban setting, almost everyone knows how to use WhatsApp. So we created a WhatsApp group for every patient. And in every patient group, we put 3 of our nurses and an admin. So from that moment on, anytime the patient has any problem, if she vomited, she would just go and type, I vomited. Or someone who was taking care of her might say, my mother just went diarrhea. And so within a few seconds, one of our nurses would react. And we saw that that particular thing was very, very useful. I'll just highlight one particular situation where a post-COVID patient had come home. And because we're taking good care of their family, they said, please take care of, monitor our mother also, the father. And a week later, one day, frantically, the daughter types in saying, my father is blabbering. And literally within 15 to 20 seconds, 2 of our nurses were on a video call with the patient, identified what it was, made them get on a car and head out towards the hospital. Another group of our team went ahead and secured a bed in a particular hospital, directed them to go there. And on the 29th minute after recognizing early symptoms of stroke, the patient was being treated in an emergency ward for stroke. Had it not been for that monitoring, the family would surely have missed it. So we are able to see how this monitoring is helping out. So in a COVID situation, we had this continuous monitoring. And if you just hit the next button, Pavan, just click, you would see that escalations was done, instructions was passed on from the doctor. So there was a seamless back and forth. On an average, we did about 2,000 telecalls between the nurses and the doctors, or the doctors and the patients for a month. And this, on an average month, we had anywhere between 150 to 200 patients. And the more important aspect of this was our nurses were very, very motivated because they were having clinical experience right there almost as much as they would in a healthcare setting. Next, please. So monitoring was done using Monitoring was done using telephonic calls, video calls, and WhatsApp group. WhatsApp group, as you see, a very simple exchange. And we were able to get very focused instructions to the patient. It was clear, crisp, and we were able to actually trace an entire history. There was a situation where a patient did say, your doctor did not recognize that I needed insulin. And we were able to go, no, please go back, just a minute. And we were able to go ahead and showcase that on a particular time is when our doctor had very clearly instructed for insulin, and we arranged for a patient bedside nurse to come and help out. So I'm going to hand it over to Anuprita to talk briefly about the small documents that we use. Go ahead, Anu. Next, please.
Thank you, Manik. Thank you, Manik. Good morning, everyone. This is Anuprita here. I'm the registered nurse and registered midwife working under the team of Mr. Manik. Next slide, please. This is our sample care plan. If you can see in that, we have a demographic data of the patient, for example, like name, age, date of birth, height, weight, the BMI, the temperature, SpO2, and the date of admission is documented, and also the location of the patient. And we also have in the next row, if you can see, there is a COVID vaccine status is noted there, whether the patient has taken the COVID vaccine and what kind of vaccine they have taken, the type of vaccine, and the date is also mentioned. And the next, this in the same row, we have the COVID test column row, that is an RT-PCR test. So the date and the status of the RT-PCR is done, whether it's a patient is positive or negative. And next is the compliance. Compliance, like what the patient having compliance, like for example, if they have fatigue, the cough, so those all has been documented there. And the first symptom date is a particular thing we document. We ask for a patient, we take like, for example, if they have cough, so we document the particular date and time also is documented there. And the comorbidity, for example, the past medical history and past surgical history is being documented there. If the patient is a diabetic or hypertensive, for diabetes, we ask whether they are on regular medications, whether they're on the OHA or they're on insulin, and what type of insulin is being taken by the patient. It's all being triaged and documented in the care plan. So next is the investigations done. So it is all previous investigations which has been done by the patient. So it's there, it's documented there. And the next is the test done by us. So we generally, the doctors will prescribe the following the blood test, which is need to be done by the patient. So there we just document like a CRP D-dimer, that's for the sample care plan we just mentioned there. And next is the prescription of the patient, that's the medications. Please, next slide. Yes, thank you. So here you can see the medicine name is listed on and the dosage is being there and how they have to take that, whether the medicine is to be taken after food or before food. And for the steroids and the anticoagulants, we usually mention the from and when they have to take and when they have to stop. So from and to is being mentioned in the care plan. Then also you can see the general advices like steam inhalation on the warm saline gargle and prone position, and they have to take adequate fluids, and the other basic general advices is being documented there. Next slide. Yes, so this is a sample at-home recovery summary of one of a patient. So in this, if you can see, there is a patient name, age, gender is being documented, and date of admission and date of discharge, and total number of days, and the diagnosis, the comorbidity, the virtual check-in, that is the how many times the nurse makes a call to the patient through audio or video, and the doctor consultation is being documented, how many times the doctor did the consultation with the patient, and the brief about the medical course is being documented, and also the lab test which is being done by us. So if you can see in this, go to the previous slide, please. Yes, thank you. So here, if you can see the lab test, there is a CRP D-dimer. At the time of admission, the patient's CRP is about 39.4. At the time of discharge, that's about 25th. If you can see, the CRP value is less than 1. Okay, so it's all, because of our medications, the patient has CRP has come down. Go to the next slide. Yes, so this is a medications which is being given to the patient at the time of discharge. So these are all the examples of the medications, and the general advice is being done. For example, they have to maintain the social distance, and proper hand hygiene has to be followed, and vaccine has to be taken after 90 days, and use the face mask and safety precautions while traveling. This at-home recovery summary is being explained to the patient, and we are clarifying the doubts from the patient also. Next slide. Yes. So we also do services like post-COVID for the post-COVID patient, like rehab care services. That's for the COVID, and also for the all specialties we do the rehab care services, and for diabetes care management we do, and other telehealth services for specialty kind of patients. Next slide.
I think, we don't have to go into the details because we are really short of time. It's very nicely done, frankly. That we have to agree, but we are really short of time.
Thank you. Let me just finish with this slide. And the way forward for the community of caregivers is to assist and provide nursing, to respond to any spread of infection, to limit the spread of infection, to facilitate new lifestyles of remote care, and of course to lead the national healthcare formats using telehealth nursing. Thank you for the opportunity.